Hello, everybody. Good evening and good afternoon, friends and colleagues. Welcome to the 13th ASPA-FLEX webinar, Pediatric Regional Anesthesia Part 2. I'm Josephine from Singapore, and I will be the lead moderator for today. I believe many people enjoyed the last ASPA-FLEX Pediatric Regional Anesthesia Part 1 webinar. This time, we have gathered more experts from different countries to share their expertise on this topic. Before we start the webinar, I will quickly run through some house rules. Do send in questions or comments via the Q&A section. The chat and raise hand function has been disabled. Our moderators will highlight to the speakers the relevant questions during the panel discussion. Some questions will be answered by text by our speakers in the Q&A section. Certificate of attendance will be automatically generated and forwarded to those who submit the post-webinar survey. The post-webinar survey will be sent to you via email tomorrow, which is the 19th of July at 5 p.m. Singapore time. Please ensure that you correctly key in your full name and email address. For those who wish to watch this webinar recording at a later date and time, kindly follow us on YouTube, like us on Facebook, or visit our ASPA website. During the webinar, when a poll is launched, you will be prompted to answer the poll questions. You have about 30 seconds to respond and submit your answer. We will share the results soon after we end the poll. And after the results are shared, you may close the poll to see the slide by our speaker. Gentle reminder to all ASPA members that the 14th ASPA Annual General Meeting will be held today at the end of the webinar at 6:30 Singapore time. I emphasize that registration is required. If you have not received an email to register for the upcoming ASPA AGM, please email ASPA Secretariat Jessie Tan at any time during the webinar to get the registration link. Her email address will be posted in the Q&A section. I would now like to introduce our two moderators for today's webinar, Dr. Usha Nair and Dr. Alinda Oracion. Dr. Nair is a consultant pediatric anesthesiologist from Ipoh, Malaysia. She is a keen educator and is an advocate for day surgery anesthesia, TIVA, and patient safety. Dr. Oracion is a head section of pediatric anesthesia, head protocols and committee and pathways committee at the Rizal Medical Center at Pasig City in Metro Manila. She also chairs the Safety and Quality Practice Committee of the WFSA. And so without any further delay, I will now invite Dr. Usha to introduce our first speaker of the webinar.
Good evening, everyone. Welcome to our 13th webinar hosted by ASPA. And this evening, our first speaker is Dr. Can Aksu, who will be speaking to us from Kocaeli, Turkey. He is an associate professor at the Kocaeli University School of Medicine in Turkey and holds positions in various societies in Turkey, like the Turkish Society of Anesthesia and Reanimation. He's a committee member of the Paediatric Anaesthesia Society as well as Orthopedic Anesthesia Society. He's active in the Turkish Society of Regional Anesthesia, ASRA, as well as ASPA. He has interests in pediatric anesthesia, regional anesthesia, and orthopedic anesthesia. His topic today is on femoral nerve and fascia iliaca compartment and adductor canal block in kids. Please welcome Dr. Can Aksu. Thank you.
Thank you very much for this kind presentation, and hi to everyone who is listening us from different parts of the world. First of all, I would like to give my special thanks to ASPA for letting me be a part of this great webinar series. I really appreciate it. And today, I'm going to talk about three different blocks: femoral nerve block, fascia iliaca compartment block, and adductor canal blocks. And actually, all the nerves which are blocked by these three regional techniques, are the parts of the lumbar plexus. So first I'll start with the anatomy of lumbar plexus, then continue with the techniques and indications. And as this is a 15-minute speech, this will be only a brief description of these three techniques. So let's start with the lumbar plexus anatomy. Here's a beautiful image from Netter's Atlas of Human Anatomy, which I like and use in most of my studies. We see the lumbar plexus here and its branches as iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral cutaneous nerve, and femoral nerve, and also the obturator nerve. You can see the lateral cutaneous nerve passing beneath the inguinal ligament. It innervates the anterolateral thigh. The femoral nerve emerges from the psoas major muscle, the lateral of the psoas major muscle, and also passes beneath the inguinal ligament, and it innervates the extensors of the leg knee, flexors of the hip, and skin of anterior thigh, medial aspect of leg, and also the foot. And the obturator nerve emerges from the medial border of the psoas major muscle, and it passes through pelvis and exits via obturator canal, and it supplies the skin and the adductor muscles of medial thigh. And the last nerve we're gonna talk about is the saphenous nerve when we are talking about blocking the adductor canal. It is the distal branch of the femoral nerve, and it innervates the anteromedial knee and medial leg down to medial malleoli. And here is the cutaneous, osseous, and muscular sensory distribution of these nerves. These nerves, it is important because we need to understand what we are targeting by blocking these nerves. So let's start with the femoral block. This is the cadaveric image of the inguinal area to showing the femoral nerve, and also this is the illustration showing the femoral nerve, and it is lying between the femoral vessels and the sartorius muscle. This is the femoral triangle, as you can see here, and it gives its distal branches down to sartorius muscle. And this is how we place our ultrasound probe in inguinal crest, the inguinal region for block application. We can use either a hockey stick probe or a linear probe for the block application. It's up to our clinical conditions. And here you can see the femur. It differs from the adults because pediatric patients' anatomical depths are so shallow. And you can see femur, iliacus muscle, sartorius muscle, femoral vessels, and also the femoral nerve here. And let's have a quick scan of the area. Now you can see the pulsation here, the femoral artery pulsation, and you can see the femoral nerve here. And this is how we place our needle. We can either use an in-plane technique or out-of-plane technique for doing the block, but I always prefer in-plane technique when it's possible, of course. It's safer in pediatric patients to see the needle because we are dealing with shallow depths and more congested anatomic structures. So it's so important to see the needle. And dose for the block application is 0.2 to 0.5 milliliter per kilogram, 0.25% bupivacaine. But if you dilate more, you can use higher volumes. But as this is just a peripheral nerve block, you can achieve a successful block by using 0.4 or 0.5 milliliter per kilogram bupivacaine. Here are some indications for femoral nerve block, as femur fractures, surgery on the anterior thigh, arthroscopy of the knee, anterior cruciate ligament reconstruction, and total knee arthroplasty. We are using femoral nerve block as a part of multimodal analgesia regimen, not for the surgical anesthesia. So keep this in mind. We can't use it as a surgical anesthesia for these indications. It's the part of the multimodal analgesia regimen. And here are some complications for the femoral nerve block: vascular puncture, hematome, nerve injury, and if we use catheters, we can see catheter infections because the inguinal region is hard to keep a clean area, and we can also observe falls due to motor weakness of the quadriceps muscle. And so the second block today is the fascia iliaca compartment block. there are two different techniques to block, to perform this block, infrainguinal technique or the suprainguinal technique. And you can see here that with the infrainguinal approach, the probe position is same as the femoral nerve block technique, and you can see here, and also the anatomy is the ultrasonography anatomy is the same, but our needle position is slightly different. We put our needle a little bit laterally to place the needle under the fascia iliaca, and also to spread the local anesthetic from starting from femoral nerve to lateral femoral cutaneous nerve. And the second technique to perform fascia iliaca is the suprainguinal technique. This is relatively a newer technique in which the local anesthetic is expected to spread more extensively and block the obturator nerve, and so to cover a wider area for perioperative analgesia as in 3-in-1 block. We put our ultrasound probe longitudinally to detect the anterior superior iliac spine and shift it a little bit medially at the level of inguinal ligament. And following the identification of the anatomical structures as internal oblique muscle, iliacus muscle, and fascia iliaca lying between them, we place our needle from caudal to cranial to spread the local anesthetic more cranially to cover up all three nerves. And there might be a different option to perform a fascia iliaca block, which I would like to refer as an alternative. This is actually an ultrasonographic image from one of my papers where I defined a combination of a PENK block with lateral femoral cutaneous nerve block for pediatric hip surgeries. On a second look, I suddenly realized that I'm looking to exactly to fascia iliaca on suprainguinal region. As you can see here, femoral nerve, lateral femoral cutaneous nerve, fascia lata, and fascia iliaca here. And if we place our needle like this, we can perform a suprainguinal fascia iliaca block. And actually, I tried to perform fascia iliaca block like this, and although I have still limited data, I can say that the results are promising. It's just to keep in mind that there could be another option, but when we think about the anatomy, there might be thinking like this. There might be the obturator nerve, and if we place our needle and spread our local anesthetic like this, we could have the possibility to block 3 nerves more successfully than the other techniques. Let's have a quick check for our goals while doing fascia iliaca. In the infrainguinal approach, we are trying to block these 2 nerves, and when with suprainguinal approach, we are trying to block femoral lateral femoral cutaneous nerve and also the obturator nerve. Maybe we could block 3 with the alternative approach. And here are 2 beautiful studies which I would like to refer for the dose for this block application. One from Dr. Vurusheli and one from Dr. Boretsky. And Vurusheli and her colleagues studied the infrainguinal fascia iliaca block using 1 milliliter per kilogram local anesthetic and showed the successful application of the block. And the Dr. Boretsky and her colleagues studied the suprainguinal approach using 0.35 to 0.6 milliliter kilogram, and they concluded as it has a high technical success rate in older children, actually when using readily identified landmarks. And in parallel with their results, I recommend using 1 milliliter per kilogram for the block application because it's a volume dependent block. So we need volume to fill up the space and block all the 3 nerves. And in current literature, I found out that aside from its use in anesthesiology for analgesia in hip surgeries, pediatricians and also the doctors in emergency departments are also using this technique to control acute pain after femoral fractures in emergency departments. And also, fascia iliaca compartment block has shown to be successful for reducing the agitation in these children along with providing analgesia. And I think this is important to show for showing the benefits of regional anesthesia other than providing analgesia alone. And finally, our last block is the adductor canal block. Here we see a cadaveric image of distal and proximal adductor canal. Here is the proximal foramen, and here is the distal foramen, and also a beautiful illustration from Nettel's Atlas of Human Anatomy again. And we see the cross-sectional anatomy of the area. And as you can see, the nerves here, and it passes medially and deep when it moves down to knee. And this is a very good cadaveric study evaluating the injected spate using proximal approach. And it concluded as the proximal adductor canal injection has a consistent dye spread pattern, capturing the posteromedial branch of nerve to vastus medialis, superior medial genicular nerve, and saphenous nerve, genicular branch of obturator nerve. So they recommend using a proximal approach to have an effective motor sparing block. So let's have a look for the sonographic anatomy of the block. You can see the vastus medialis, sartorius muscle, gemellus muscle, adductor magnus muscle, and femur here, and femoral vessels here, and the saphenous nerve lies in between them, and we place our needle like this to achieve a successful block. And of course, you can use an out-of-plane technique again for this block, but I prefer using an in-plane technique. And this is the scan of whole thigh starting from the inguinal region down to distal adductor canal. You can see the sartorius, femoral vessels, and also the femoral nerve here, and it turns to saphenous nerve when we are moving down to patella. You can see they are going deeper, sartorius muscle coming medially, they are going deeper, and the saphenous nerve is here. Here are some indications of adductor canal block and also the complications of the block. And as the target area of this block is in close proximity to femoral artery, and so the bleeding and hematoma could be seen, but I would like to talk about the last because the block is volume dependent block, and we use a relatively high dose of local anesthetic for this tiny area. So the last could be a potential complication and should be kept in mind. And this is a case from our department. We used adductor canal block in combination with the sciatic block and placed an adductor canal catheter for continuous analgesia. This is a free flap surgery in a pediatric patient. I share this for a reminder as a last message from my presentation, because the most critical point for the safety of peripheral nerve blocks might be the dose of the local anesthetic. And as you can see here, we use block combinations and use higher doses of local anesthetic, but we always calculating the total amount of local anesthetic that we use. So please take it as a take-home message from this presentation. Always calculate the total amount of local anesthetic when you perform a pediatric regional anesthetic technique. And I know there is limited knowledge about the safe local anesthetic dose in current literature, but ASPA pain management ladder initiative recommends 2.5 milligram per kilogram bupivacaine for peripheral nerve blocks in kids. And Suresh and colleagues recommends a lower dose of bupivacaine for lower extremity peripheral nerve blocks as 0.5 to 1.5 milligram per kilogram bupivacaine. And as I said before, so please always calculate the total amount of local anesthetic. And this is the end. Many thanks for your patience. Hope you enjoyed the presentation and hope we always have safe and happy kids all around us. And also, I hope to have face-to-face meetings in the near future. See you soon. Thanks.
Thank you, Jan, for a very informative talk. And to the audience, I would like to remind you that if you have any questions, you may post them in the Q&A section on your screen, and we will attempt to answer them at the end of this webinar. I will go on to introduce our second speaker for this evening, who is Dr. Vrushali Ponde, and she will be speaking to us from Mumbai. The topic this evening is the commonest upper and lower extremity blocks in children, and she is affiliated and very active in various societies in Mumbai. She's a mentor, she's a program head, and she is a pediatric anesthetist. And I'm sure many of you have heard her before, and you will always learn something new. Please welcome Dr. Vrushali Ponde. Thank you.
80,000 hours. These are the number of hours an average anesthesiologist really works in the operation theater, and it could be more. To make it even more worthwhile, we need to be keeping abreast with what is changing, and paradigms shift all the time. There is a concrete paradigm shift towards pediatric regional anesthesia for obvious reasons. And the next 20 minutes, we are going to look into the commonest upper and lower extremity blocks in kids. Before we embark, certain thoughts that I would want to share. The upper extremity blocks definitely hold a bigger sway than the lower extremity blocks, because for lower extremity blocks, we have an alternative of the central neuroaxis. Secondly, there is no conflict of interest, and of course, all required consents are taken. And of course, I am biased towards this subject. The paradigm that we are going to look at is interscalene, supraclavicular, infraclavicular, and axillary. We are going to look at the popliteal, mid-thigh, dosages, and local anesthetic drugs in nutshell. We can't look into each and every block that is possible with the upper and the lower extremity for the sake of time. Well, coming to the upper extremity, and let's focus more on it, the anatomy of the brachial plexus as such, well, the formation and the trajectory almost is the same. However, the structures here are very, very superficial. The corollary to it is what is going to get damaged around it is also just where they're waiting to get damaged. The positive point is sonoanatomy is pretty clear, and linear probe generally shows most of the structures. You hardly need any other probe in pediatrics. We will look at each approach in a case-wise manner, so we really add a lot of clinical knowledge to it. Let's look at a neonate with osteomyelitis left shoulder. Well, before we go to the interscalene block in a neonate, let me take you to slightly grown-up kids. The picture, the photograph here is telling you all about the ergonomics of the probe and the needle. Coming to the ultrasound scan, all you need to do is take up this scheme and put it here, superimpose it as it were, and we will understand the sonoanatomy in a grown-up child. So this is the lateral, this is the skin and the subcutaneous tissue. This is the sternocleidomastoid, this is the anterior scalene, this is the medial scalene, and these are the interscalene brachial plexus. Now, how do we decipher each here? So this could be C5 and this is the C6, actually divided. This is the C7 and this is the subclavian artery. Well, they all look as if they are together in one field, unlike adults, because the footprint is showing us far more. This is the brachial plexus and interscalene, again, in a smaller child. If we want to really see how a dynamic scan looks like, it would be something like this. So this would be C5 and C6 here. The needle is already here and it's injecting. I've already shown you two different age groups and how the interscalene approach brachial plexus will appear in a dynamic scan and the drug spread too. Let's come to the neonate that we were talking about. Now this is the subclavian artery. Let me orient you even before, and here the brachial plexus would be seen, since it's rather interesting in a neonate because it doesn't really appear the way it appeared in a grown. So this is how it would look here, and you can actually really even understand the heart rate of a neonate from the visibility or the pulsations in the field itself. If the surgery is invasive enough, this can be even tunneled and secured. But a confession here, neck is extremely mobile, children are very wriggly, and these catheters come out more often than stay. Coming to case number 2, an 8-year-old has a cyst in humerus. A good block to be given here is a supraclavicular block. The ergonomics is shown in the picture. The scheme is right here. This is the first strip, the subclavian artery, and the nerves around. So now let us make the sense in ultrasound. So this is the orientation marker. This is lateral skin and subcutaneous tissue. This is the lower belly of the omohyoid. This is the subclavian artery, the first strip that needs to be noted. And this is the bunch of grapes, as it were. Well, we can sit and decipher the superior, the inferior, and the posterior here. But however, to begin with, the bunch of grapes is more than enough. And this is the needle which has been approached, and we are just about to inject. A couple of cautious thoughts that we need to have is these are actually hypoechoic rings and shouldn't be touched and need not be distended at all. And the drug injection should happen in the hyperechoic intertwining tissues, as it were. So 2 things that need to be very, very fixed in our mind is we need to identify the rib and the pleura. Now, this is the rib because it isn't showing anything underneath, and this is the pleura because it's showing everything underneath. And we need to know these 2 structures so that we do not damage any other structure that we don't intend to at all. This is the subclavian artery, and you can see a mirror image here, which is an artifact, obviously, and we need to know artifacts as well. So coming to the third block, which is an infraclavicular block, a good case for it is, say, 11-month-old, 9-kilogram female baby, bilateral club hand for radial club hand repair. Well, the ergonomics is shown in the picture, and the sonoanatomy is going to unfold this way. This is the capillate end, that's the caudal end, this is the anterior. So skin subcutaneous tissue, pectoralis major, pectoralis minor, that's the pleura, and here is the subclavian or the axillary artery, and here is the axillary vein, and the cords would be all around. Let us look at different scans to understand. Now, this is a dynamic scan, again, skin and subcutaneous tissue, pectoralis major, pectoralis minor. Let's start with the scan. The lateral cord would be here, the posterior cord in this particular area, and the medial cord here. The needle shall be approaching from the orientation marker. We are at the lateral cord and the injections are already happening. You can see that this is the lateral cord seen even better. We could go towards the posterior cord and inject. So we were a bit close to the artery. We have redirected, injecting at around 6 o'clock, which is the posterior cord. And really a medial cord injection is not required because you can see the whole field is actually being bathed with local anesthetic, and the medial cord is right in between the axillary artery and the axillary vein. Let me take you to a scan of an adult and see the difference. At 2.7, you see in children. At 2.4, this is actually a deeper block in adults. And we always claim that in adults, we need to always put the drug at the posterior cord and not anywhere else to get a proper block or a bigger efficacy. In children, we have seen somehow that this isn't true, because even if we keep ourselves at lateral cord, we get the same block clinically as well as radiographically. These are beautiful blocks for catheter placements, especially the intraclavicular renders itself very well due to the flat anatomy here, and it's really a boon due to many other reasons other than pain relief, as it is shown in this case. Even these are the cases where the ischemic hand actually can be made into an improved vasculature scenario due to the microvascular changes that a continuous blocks really offer. So coming to the newest here, that is costoclavicular, described by Dr. Manoj Karmakar, and this is the view. This is, of course, the ergonomics. This is the sonoanatomy view. This is the axillary artery, the lateral cord, the posterior cord, and the medial cord. They all are together and not around the artery. So this is the main benefit. Let's look at the dynamic scan. That's the clavicle. Slide just below the clavicle in a transverse way and start seeing the posterior, the lateral cords, and the medial as well. This is the artery, and the needle simply has to be put at one point, of course, avoiding the hypoechoic structures, and we can inject. Really, we need not have to go towards each and every block, or rather cord. Coming to case 4, a 3 years old goes for a family outing, crushes his finger and is brought to the hospital. So now actually a surgery is required pretty well urgently, and a axillary block is a good block that can be given. This is the ergonomics I'm showing you, and it's very simple again. Look at the scheme. So this is the biceps, this is the coracobrachialis. This is not seen here because the needle reverberations are actually kind of, masking them. This is the axillary artery. The axillary vein is going to get compressed, but you will see that it opens it during this dynamic scan. This is the triceps and this is the humerus. So now let us see the dynamic scan. This is the injection of the local anesthetic, really opens up the space, and that's all that is required in very small babies. We really need not decipher where is the median nerve, where is the ulnar nerve, and where is the radial nerve. However, for the sake of completion, the median nerve is usually at 12 o'clock, the ulnar nerve is usually at 6 o'clock. The radial nerve, I'm sorry about this, the radial nerve usually is at 6 o'clock, and the ulnar nerve is usually at, say, sandwiched between artery and the vein, and usually at 2 o'clock. But we really need not go towards, because the anatomy here and the tissues here are very supple, and the local anesthetic does percolate. So coming to the lower extremity blocks, this is how the anatomy is. It's a huge, sciatic is a huge nerve running all across the posterior aspect. So this is how it would go. 10-month-old CTV repair. Yes, you could go with any other modality such as a PNS, but if you have a congenital anomaly such as this, you're not going to get the responses, and hence ultrasound obviously is a better bet. The baby could be kept like this. Ergonomically, it's going to show you from the gluteal till the popliteal. It could be even lithotomy, whichever way it suits us. Well, coming here is a dynamic scan, mid-thigh, or it could be anywhere along the thigh, before popliteal and just infragluteal. The anatomy almost looks the same. This is the posterior. Now orient yourself very well. And this is the posterior, and this is the upper part of the table, as it were. Skin subcutaneous tissue. This is the biceps femoris. This is the sciatic nerve. Somewhere here you would find the posterior cutaneous nerve. You would see the needle coming out from here in the scan, making its way towards the sciatic nerve. This is the needle now. Once it starts injecting, it will be seen even better. So because the hypoechogenicity or the anechogenicity of the drug gives a better vision, in fact. And once you have given the drug all around the sciatic nerve, this anechogenicity can be used as a background to have a catheter placed, which would look something like this. So this is the 2He needle, which has come in here instead of a simple needle, and you can actually put in the catheter. You will see the catheter jetting out from the tip of the 2He needle. Tunnel this catheter, fix it, put an infusion, and that gives you an intense analgesia, or rather the analgesia that you need with a sensory motor separation, depending upon the concentration of local anesthetic you use. And if we use 0.1% of ropivacaine or 0.2% of ropivacaine, even we get a good sensory motor separation. Well, popliteal sciatic is an easiest block to administer. So this would be, the probe is kept at the crease and just slide it above so that we start seeing the sonoanatomy, which is as follows. This is the posterior of the child. This is the anterior of the child. Posterior leg. This is the lateral, and this is the medial. Skin subcutaneous tissue. Since this is the lateral, of course, this is the common peroneal, and this is the tibial. They are almost together, but ready to diversify. So this is this muscle mass here is semimembranosus, semitendinosus. This is the biceps, and that's the femur. Remember, we called this the lateral, and hence the nomenclature followed. So once we inject at this particular point, you will see that the nerves are actually seen separating from each other, and this is supposed to be the accurate injection. What is the real advantage of lower extremity blocks? Just to begin with, this is what we had pondered on. Now, this is a baby in the post-operative room, 2 hours after the operation. A lobster foot is repaired, unilateral surgery, a sciatic nerve block is given. And here we go. Now, this is how it happens. The face looks as if it's in agony. So this is, we see he gets pacified with a bottle of feed. This is going to tell you a lot about pediatric post-operative pain management too. And as a regional anesthesiologist, I'm curious whether it is just a momentary pacification or pain relief is going on. I nudge the operated foot and he suckles without any problem. I nudge the non-operative leg and this is what the response is. So you do not give anesthesia to the limb which is not getting operated. We do not give concomitant urinary retention. And those who have practiced sciatic nerve block would obviously know that the analgesia lingers far longer than the central neuroaxis block. In nutshell, the local anesthetics and their dosages is given here. It's very easy to calculate these infusions. Yes, it is 0.2 milligram per kilogram per hour of ropivacaine or bupivacaine in the strengths that I'm showing you here in the slides. For neonates and infants and for older kids, it is 0.4 ml, 4 milligram per kilogram per hour and not ml. Well, so this is one reference that gives you a proper explanation of the dosages and the drugs. Complications, yes, there can be complications at the puncture point, trajectory of the needle, and last, which shall be taken by the speakers coming next in. Compartment syndrome is something that needs to be pondered upon. Yes, it is a real stuff. We need to be worried about it. At the same time, as regional anesthesiologists, we can be, in fact, not hampering, but helping to recognize it if we only give analgesia and not a dense, blocked, dead extremity. So there is no evidence really that RA increases acute compartment syndrome as long as there is a sensory motor separation, as long as the child can move the fingers, as long as a child is just about comfortable with the local anesthetic infusion going on. And anything that worsens, don't step up the infusion, but call the surgical colleagues to look into it. So to end, stop underestimating regional anesthesia. Ongoing, improve RA skills and have a case-to-case approach. Sometimes RA can be simply contraindicated. Thank you very much for listening to me. And this is what I had to say about the lower and upper extremity blocks in children. Thank you very much indeed.
Everyone. Thank you, Usha, for handing it over to me right now. And now moving on, here's another very interesting block to be discussed by our colleague from Australia. She's a consultant anesthesiologist at Flinders Medical Center, Adelaide, Australia. She is a South Australian representative for Australian Society of Anaesthetists, and she took her fellowship in pediatric anesthesia and pediatric regional anesthesia at the Boston Children's Hospital, USA. Her interests evolve around pediatrics. So it's all about pediatric anesthesia, regional analgesia, pain medicine. She's also interested in vascular anesthesia and orthopedic anesthesia. So friends, please welcome Dr. Cheryl Chewy.
Thank you, Dr. Vrushali, for a very interesting and
Thank you for your kind introduction. Today I'm going to be talking about bilateral suprazygomatic maxillary nerve blocks for cleft palate repair. I have no disclosures or conflicts of interest. Cleft palate is one of the most common congenital malformations. It occurs in 0.1 to 1.1 per 1,000 births. Cleft palate repair is often performed at an early age to avoid recurrent respiratory tract infections, to avoid speech and feeding difficulties, and to avoid the social and psychological implications that it has for both the child and the family. There is a risk of postoperative airway obstruction that is associated with the surgery itself, postoperative opioid use, and sometimes associated syndromes. Cleft palate repair is a painful operation, and without a regional block, most children will receive opioids postoperatively. There was a retrospective study published in Paediatric Anaesthesia back in 1999, and they looked at 200 children who had a cleft lip or palate repair, and they found that 97% of these children received opioids postoperatively. 3 of these children had profound respiratory complications, and one of these was respiratory depression that was directly attributed towards opioid use. So opioids are often and frequently required after cleft palate repair, and they do increase the risk of airway and respiratory complications. Cleft palate is most commonly an isolated malformation. However, it can be associated with a syndrome. And these syndromes can increase the likelihood of postoperative airway and respiratory complications. And this is compounded by opioid administration postoperatively. The most common syndromes are listed here on the screen. So Pierre-Robin sequence is associated with micrognathia and glossotosis. 80% of these children have a cleft palate. Treacher-Collins syndrome is associated with micrognathia and maxillary hypoplasia, and also choanal atresia. 28% of these patients have a cleft palate. Goldenhar syndrome is associated with hemifacial and maxillary hypoplasia, and also C-spine abnormalities. And the velocardiofacial syndrome, 22q11 deletion, is associated with velopharyngeal incompetence. And 30% of these children have a cleft palate. Cleft palate is also associated with obstructive sleep apnea, and these children are prone to aspirating and recurrent respiratory tract infections. So all of these factors, combined with the use of postoperative opioid administration, increase the likelihood of these children having airway and respiratory complications postoperatively. So how can we modify this risk? So there are a number of analgesic options, including regional and systemic analgesia. The regional analgesia options are listed here on the screen. So a palatal block involves blocking the greater and lesser palatine nerves and also the nasopalatine nerve. However, these blocks require an intraoral approach, and there is a risk of causing local bleeding and a hematoma in the surgical field. So this is not part of my practice. There's also the bilateral infraorbital maxillary nerve block. However, this block does not provide complete coverage of the entire palate. Also, this block is associated with a risk of orbital puncture and also intracranial injection. So I do think the best regional block option is the bilateral suprazygomatic maxillary nerve block, and this is what I'm going to be discussing in a moment. Of course, there is also local anesthetic infiltration by the surgeon directly on the surgical field. And I think this is a nice way of complementing the suprazygomatic maxillary nerve block, especially if you use an adrenaline-containing solution. This helps minimize surgical bleeding on the field. And of course, there is systemic analgesia, and absolutely you should utilize the non-opioid options, including paracetamol and non-steroidal anti-inflammatory drugs. So what's the evidence for bilateral suprazygomatic maxillary nerve blocks for cleft palate repair? There are a few prospective studies. There's a descriptive study and a couple of randomized controlled trials that are double-blinded, examining the benefits and risks of these blocks. And overall, they found that these blocks reduce the intraoperative and postoperative opioid requirement. They reduce the risk of opioid-related respiratory complications. They facilitate earlier return to oral feeding, and there were no significant complications at 5 days or 3 months postoperatively. And that was in one of the bigger randomized trials. So I'm going to look now at the anatomy of the maxillary nerve. The maxillary nerve is a purely sensory nerve, and it is a branch of the trigeminal nerve. So on this image on the left, you can see here the area covered by the maxillary nerve. So it innervates the lower eyelid, the alar of the nose, the upper lip, the bone of the maxilla and sinus, and of course it covers the soft and hard palate. In terms of its pathway, it begins in the middle cranial fossa. It then passes through the foramen rotundum into the pterygopalatine fossa. It then passes through the infraorbital canal and out through the infraorbital foramen, and then innervates the floor of the orbit. To perform the suprazygomatic maxillary nerve block, we inject local anaesthetic to infiltrate the pterygopalatine fossa in this area just here. This is another image just demonstrating where we aim to inject local anaesthetic. So this is the face of the patient. This is the zygomatic arch. The needle puncture site is above the zygoma, and then the needle is directed in this direction, and local is infiltrated into the pterygopalatine fossa. This here is the sphenoid bone, and this is the maxillary bone. This is another image demonstrating the needle trajectory and some of the important landmarks. So this is the face of the patient. Here is the posterior orbital rim. This is the zygomatic arch, but it is cut off and broken on this skull. And the needle puncture site, like I mentioned before, is above the zygomatic arch, and we aim to inject local anaesthetic in the pterygopalatine fossa just here, this area that is marked by pink on the screen. This is the maxilla, and this is the sphenoid bone. So there are a number of indications for this block, including cleft palate repair, surgery on the maxilla or the ethmoid sinus, trigeminal neuralgias, and it can also be used on adults in addition to children. In terms of preparation for this block, I use a 22 gauge short beveled 5 centimetre needle with a linear array ultrasound probe. In terms of the local anaesthetic, I use 0.15 mils per kilo of ropivacaine, 0.2%, and I use a maximum of 5 mils, and this is for each side. I then calculate the remaining local anaesthetic based on the child's weight, and I give it to the surgeons to infiltrate directly on the surgical field. And I would give them an adrenaline-containing solution to maximise that effect in terms of minimising surgical bleeding on the surgical field. So to perform the block, I would use an aseptic technique. The child should be supine, and you can tilt the head a little to one side just to make ergonomics a little easier when you're performing the block. And these are the important surface landmarks. Here is the posterior orbital rim. Here is the zygomatic arch. And the needle insertion site is at the junction of these two landmarks. So I would puncture the skin right here. And the ultrasound probe is placed below the zygomatic arch on the child's cheek. Here is another image just demonstrating how to hold the ultrasound probe for this block. As you can see, it's a linear transducer, and it is about at a 45-degree angle to the child's face, angled in sort of an upwards direction. Here is the posterior orbital rim, and here is the zygomatic arch. These are important landmarks when performing this block. So these two images demonstrate the needle direction, and I'm actually in this, for the purposes of this photo, I was using a blunt needle with an empty syringe because I was not performing this block on this child. So hold the ultrasound transducer at a 45-degree angle to the child's face. And then the initial needle puncture is perpendicular to the skin. I then advance the needle to touch bone, which is the greater wing of the sphenoid. Once I've touched bone, I would withdraw the needle 2 or 3 millimeters and then redirect it at a 45-degree angle towards the ultrasound probe. And you should be able to get a out of plane image of the needle, and you're aiming to inject local anesthetic in the pterygopalatine fossa. So this is the classic image that you should see. Here is the sphenoid. This is the pterygopalatine fossa where you're aiming to inject the local anesthetic, and this here is the maxilla. You can't usually see the nerve sitting in the pterygopalatine fossa because it's very small. The important things to visualize include the bones, the needle tip, and also the internal maxillary artery, because you don't want to hit that. This is an unmarked version of the same image. So here you can see the sphenoid. This is the pterygopalatine fossa, and here is the maxilla. Like I mentioned before, watch out for the maxillary artery. I think it's important to try to avoid hitting this by accident. So here is the maxilla, here is the sphenoid bone, this is the pterygopalatine fossa, and in the center of the screen here is the internal maxillary artery. I have this little video clip to play just to demonstrate the pulsating artery. I'll just play it one more time. Great. This is another video clip, and this just demonstrates the local anesthetic injection into the pterygopalatine fossa and what it should look like. So this is the maxilla. Here is the sphenoid bone. This is the pterygopalatine fossa. This is the needle tip, and you can see local anesthetic filling this fossa. I'll just play that video one more time. So you can see here the local anesthetic filling this fossa, and it spreads all the way up here. Other important points, the angle of needle insertion does not change with increasing age, not significantly. However, the depth of needle insertion does increase with increasing age, which kind of makes sense when you think about it. In terms of complications, there really aren't any complications other than a superficial bruise that's reported in the literature. These complications are fairly general and include block failure, local hematoma, pain, and also nerve injury, like with any block. However, there are no serious complications or permanent complications that have been reported in the literature so far. So in summary, the suprazygomatic maxillary nerve block is opioid sparing and allows early feeding. It's easy to learn and has a low risk of complications. Thank you.
Thank you, Cheryl, for that wonderful lecture. Now, going on, local anesthetics are often incorrectly thought to be without side effects or toxicity. Despite the widespread use of local anesthetics, awareness of local anesthetic systemic toxicity and knowledge of its management are lacking. Now, allow me to introduce our very own expert from Turkey, who is an associate professor at the Department of Anesthesia and Reanimation, at the University of MAA Acıbadem, Istanbul, Turkey. She is a very active member of the ASPA. She is a member of the Scientific Committee of the Pediatric Anesthesia of Turkish Society of Anesthesiology and Reanimation. She is also the country representative of Turkey at the WFSA Pediatric Anesthesia Committee. Of course, her interests revolve around pediatrics as well. And she has some interest too in geriatric anesthesia and regional anesthesia. Friends, please welcome Dr. Zehra Serpil Ustalar Ozce.
Thank you for the nice introduction, Erlinda. Good afternoon to all colleagues and friends. Now, this is the very last talk of our webinar series this year, and it's about last in kids. Hope it is the last in ASPA-FLEX, but not the least. Hope we'll meet next year. We have listened and learned a lot from very precious experts about regional blockade in children. As we know, local anesthetists are commonly used by various medical and surgical specialties, both by anesthesiologists and non-anesthesiologists, also by dentists. Local anesthetics really provide good and effective pain relief. However, local anesthetic toxicity remains a very rare, potentially fatal complication with an overall mortality rate of 4 to 10% from reported cases. I'm happy to have no disclosures, no videos, no case presentations related to the topic. Hope never will have. Hope nobody will has any photos or videos related to the topic. When we talk about lust, we have to discuss a little bit of pharmacodynamics and pharmacokinetics in kids, and we go over some facts about lust in kids. We will talk about the recent guidelines and note some safety precautions related to lust. As we know, local anesthetics have lipophilic and hydrophilic components linked by an amide or ester bond. We have esters and amides, and esters undergo metabolism in the plasma by plasma cholinesterases, and so they have short half-lives and decreased potential for metabolism. This explains the resurgence in the interest in using the ester local anesthetic 2-chloroprocaine for continuous epidural infusions for postoperative analgesia, especially in neonates and infants. Amide local anesthetics are metabolized in a hepatic way, and the cytochrome P450 enzyme system, and bupivacaine has an active metabolite, so they have more toxicity profile than the ester ones. They have longer lives, and they are combined by alpha-1 acetylglycoprotein, and this protein increases adult levels in the age of 1 in children. So clearance is reduced and terminal half-life is prolonged to 3 to 8 times in neonates and infants. So having immature organ systems and reduced plasma levels of proteins, neonates and infants are more prone to local anesthetic toxicity. Dr. Suresh Vargas and Savar Dekar has updated us on regional pediatric regional anesthesia about safety issues, and their very interesting review of current literature. Dr. Boretsky and Ms. Ramesh, Dr. Ramesh has discussed about lust in children based on recent case reports. The good news is that the Pediatric Regional Anesthesia Network has reported 7 cases over 100,000 blocks, and which is very similar to the other French-speaking societies of pediatric anesthesiology numbers. In these numbers, non-anesthesiologists are not included. Luckily, there are no long-term consequences, and the stated guidelines provide a safety margin, and no last deaths in kids has reported in the recent 10 years. However, the bad point is that high-quality studies are lacking. Use of ultrasound and test dose did not alter the risk or incidence of LAST in kids. The greatest risk is in infants below the age of 6 and 12 months. The authors has stated survival benefit in LAST in kids. However, Boretsky and Ramesh has stated a selection bias that only successful restorations are reported, not the unsuccessful ones. So we cannot say that there are no complications like that. We know that there's an increased risk of LAST in acidosis, hypoxia, and the smaller infants, especially newborns. Electrolyte abnormalities, liver disease, heart disease, and metabolic syndromes have more prone to having LAST when local anesthetics are used. LAST affects the central nervous system and the cardiovascular system. With most local anesthetics, central nervous system toxicity occurs at doses and plasma concentrations lower than those produce cardiovascular toxicity. This differential effect in central nervous system versus cardiovascular toxicity provides some degree of safety because the central nervous system symptoms like seizures are generally more amenable to treatment than the cardiovascular effects. As it is seen in awake patients, the symptoms like tinnitus, the metallic taste or perioral numbness or agitation, difficulty in speaking can be expressed in adults, but not the infants. We can see central nervous symptoms if the child is awake. However, we usually do our blocks when the children was anesthetized. So we cannot see the agitation or alteration in mental status under anesthesia. Cardiovascular symptoms in which bradycardia is the most common one, conduction blocks, white QRS complex, and PR interval widening, ventricular tachycardia, and ventricular fibrillation, and asystole can be seen as symptoms of LAST under anesthesia in infants. These findings suddenly compensates and progresses to ventricular fibrillation. We are very familiar with the maximum doses of the local anesthetics. However, in their review, they stated that in the cases they had reviewed, LAST occurred in local anesthetics doses less than, equal to, within, and greater than the recommended doses. So when we think about maximum allowable doses versus minimum efficacious dose, it is strongly recommended that please use the minimum efficacious dose during your blocks. In the review of Dr. Ramesh and Boretsky, they had reviewed 31 cases reported recent 5 years. Most LAST cases has been occurred in the operating rooms, which is a lucky thing. Bupivacaine followed by lidocaine and ropivacaine, and penile blocks were followed by caudal and local infiltrations. Most of the cases, all of the cases we can say, because 30 cases has been occurred within 30 minutes after the bolus dose, which says that this can be because of the unwanted intravascular injection. When they used the landmark methods, they had seen LAST in 20 patients. However, even they use ultrasonography and fluoroscopy for guidance, LAST has been also seen. LAST occurred in anesthetized children more than the conscious ones. The most encountered CNS symptoms were apnea, seizures, altered level of consciousness. The cardiovascular change symptoms were the ECG changes, widening of QRS, STT segment changes, peaked or inverted T waves, and hemodynamically significant bradycardia, asystole ventricular tachycardia, hypotension, and cardiac arrest. Regarding the safety, in their review, Dr. Burshali Ponde and Akiwamara and Singh has been also stated in their review. To take precautions is important and more easier than treating when LAST occurred. So having no complication is better than having complications and trying to treat it. So local anesthetic should be administered in a setting where standard ASA monitors can be applied. So if you don't have any monitors, please do not use local anesthetics. Aspiration of syringes prior to injection of local anesthetic is strongly recommended to prevent accidental intravascular injection, although this can be insensitive also. Access to airway rescue devices should always be available where local anesthetics are used. When there is local anesthetics are being used, last kit always be there, and it should contain IV tubing, several syringes for administration, 20% lipid emulsion, and the guideline you use should be printed and should be with the kit to read when you are treating the patient. The other safety measures are like stated in the all in the reviews are please maintain adequate hemodynamic and respiratory function by ensuring adequate oxygenation and ventilation. Please identify high-risk groups that may require dosage modifications. Please identify patient populations with comorbidities, hepatic, renal, and cardiac, and please adjust dosage as needed. It's important to identify administration of high-risk states like intrapleural or fascial plain blocks, where local anesthetics are more absorbed. And please decrease the dose by 20 or 30% of maximum dose. Adhere to those dosing guidelines for both single bolus and continuous infusions. Please use lowest effective product concentration and smallest volume of local anesthetic agent. Use ultrasound as needed to limit the volume required. Please consider using local anesthetic with lower risk of toxicity. As it is seen in the reviews that all the case reports, 80% are within the 5 minutes of bolus dosing. And this means that these are due to the inadvertent intravascular injections. So slow, careful, incremental injections are essential. Frequent aspiration prior to each injection, not only the first one, is strongly suggested. Utilization of intravascular marker like epinephrine is important. Use of ultrasound guidance for inadvertent systemic injection makes us diagnose earlier. So, and also monitor your patients 30 to 45 minutes to account for absorption. When we see or diagnose the last, how do we manage it? There are 3 important points: airway, cardiovascular support, and intralipid emulsion treatment. I don't go over the airway issues, which is very familiar to all of us. Now, I have a question for you. During last, which antiarrhythmic agent you would choose? Beta blockers, calcium channel blockers, lidocaine, amiodarone. When we have to restate the patient during last, we have to reduce the doses of epinephrine below 1 mg per kilogram. And while treating hypotension, vasopressin and or phenylephrine should be avoided. And treating ventricular arrhythmias with amiodarone is suggested, not with the other agents. Intralipid therapy should not be delayed. As soon as the diagnosis is done, we should start immediately the intralipid emulsion solution. We give an initial intravenous bolus, 1.5 miles per kilogram over 1 minute, and start the infusion at 15 miles per kilogram per hour rate. Subsequent infusions are lower, and the infusion should be continued for 10 minutes after hemodynamic stability is achieved. The typical maximum dose of intralipid therapy is 10 miles per kilogram within the first 30 minutes. After 5 minutes, if we cannot achieve the cardiovascular stability or adequate circulation is not achieved, we can give a maximum of 2 repeat boluses of the same doses, leave 5 minutes between the boluses, and we continue the infusions, doubling the rate to 30 miles per kilogram per hour. The maximum cumulative dose of intralipid solution has increased to 12 miles per kilogram in total. When we try to manage the seizures, benzodiazepines are the first-line treatment drugs since they have greater hemodynamic stability. Propofol or barbiturates are effective also to suppress seizures. However, it's recommended to avoid propofol as this can cause further cardiac depression, which is the main problem. After last, if the patient had developed neurological symptoms, he should be observed at 2 hours after recovery. If there were cardiac symptoms, the patient should be observed 6 hours after recovery. If there had been a cardiac arrest, we should treat the patient as appropriate in the pediatric ICU. It's essential to arrange safe transfer to a clinical area with appropriate equipment with suitable staff until sustained recovery is achieved. In order to exclude pancreatitis by regular clinical review and including daily amylase or lipase assays for 2 days, the cases should be reported wherever possible. Lipid Rescue is another website for that, because these cases are very important for education and the future of LAST. So when you diagnose LAST, stop injecting local anesthetic, call for help, secure your airway, give 100% oxygen, ensure adequate ventilation, confirm or establish your IV line, control seizures, control the cardiovascular status, and draw blood for analysis, but do not delay definitive treatment. CPR and managing arrhythmias may be refractory and may take longer than 1 hour. If it's available, cardiopulmonary bypass or ECMO is suggested. Propofol is not a substitute for intralipid emulsions, and lidocaine is not a suitable antiarrhythmic agent for the arrhythmias. So last in kids, infants are the most common patient group, manifest with cardiac symptoms. Local anesthetics tend to be administered using the maximum allowable dose, and without the ultrasound guidance has more LAST cases. Needle aspiration, test dosing with epinephrine fail to reliably predict LAST, and intralipid emulsions given within 10 minutes are very effective, so do not delay giving intralipid emulsions. Local anesthetics are beneficial. LAST continues to occur. However, awareness is crucial, and death and morbidity are rare, hope to be rare. So thank you for listening to us and for being with us. We are waiting for your questions.
That was a great talk, Serpil. Really, I think everybody really did a good job. So right now we're going to proceed to our Q&A portion. Is that okay? So I request all the panelists to have their video on. So that everybody will have an idea or be refreshed as well. Serpil, I'd like to know, but because, your talk was so comprehensive, I don't really know what to ask anymore. But may I remind to the audience that if you have more questions, please put it into the Q&A section just underneath at the lower part of the screen, okay? So let me go back to Serpil. Since your talk was really very comprehensive, the only thing I can ask you now really is there anything you would like to emphasize to the audience about local anesthetic systemic toxicity in children?
Thank you, Erlinda. Now, please, when you use local anesthetic agents, please keep your LAST kit with you and do not use propofol instead of lipid emulsions. You can use propofol for control of seizures, but not propofol. And lidocaine is not the antiarrhythmic of choice during cardiovascular effects of local anesthetics toxic effects of local anesthetics. Since amiodarone is the right choice, the others are cardiovascular depressants, and we don't want hypotension. So we don't use systemic vascular resistant increasing agents as well. And please keep your last kit with you whenever you do blocks or whenever you have local anesthesia in your hands.
Okay,
Thank
thank
you,
you
Erlinda.
for that. Thank you also for that. I'm sure the audience will remember that right now. And now may I go to Cheryl first? Okay, Cheryl, well, in the last two webinars, we had talked about pediatric regional anesthesia, and it was everybody was great in all these talks. So really, pediatric regional anesthesia is the anesthetic art to contend with right now. Now, you talked about using the block, the zygomatic maxillary nerve block for post-operative pain. But what happens if the post-operative pain extends beyond the nerve block's resolution duration? Now, if you increase the volume of local anesthetic, this may prolong analgesia but give you some toxicity. So would you consider using perineural adjuvants for this?
So as by standard with suprazygomatic maxillary nerve blocks, I would also have rescue opioid available to the patient post-operatively, available to them, because the block will wear off at some point. There is the option of adding in adjuvants like clonidine or dexmedetomidine, and there are a couple of small randomized controlled trials comparing these adjuvants to just plain bupivacaine or ropivacaine, and they show that it probably does improve the quality and the duration of the block. And interestingly, both clonidine and dexmedetomidine, when you add them to the block, it also reduces the incidence of emergence agitation. It's not my standard for this particular block because I generally get quite good success with it, but it's absolutely an option in institutions where perhaps opioids are less available or the supervision on the wards is perhaps less close than in other institutions. I think it is a good option.
Oh, thank you very much for that answer. But I guess one of the best adjuvants for such would be maternal or parental presence, right?
Oh, absolutely.
Okay, thank you for that.
And feeding them early, I think, is also helpful.
Okay, that's great. Oh, I think Dr. Vishali would like to ask something or would like to add. Yes, please, Dr. Vishali.
Yes, actually, Erlinda, you have raised an excellent point. Now that our audience have heard part 1 as well as part 2 of regional anesthesia, by no means are we trying to say that this is a sole analgesic. We are trying to go multimodal, and regional happens to be the chunk of it, but the paracetamols, the NSAIDs, especially when they're not contraindicated, they all go hand in hand. And of course, a feed on time, of course, a touch of a mom and carrying the baby around if he's not attached to an infusion. Yes, that's actually the way to go. We do it pretty preemptively, adding dexamethasone in a dose of 0.1 milligram per kilogram body weight also is going to enhance the analgesia of all the blocks that we do, and in general is going to aid a pain-free recovery. This is what our thoughts are when we talk of regionals.
Thank you, Vishali. And I am right, it is an art. Okay, back to you, Usha.
Thank you, Linda. I would like to direct this question to John. There is a question in the Q&A section that says, do you use nerve stimulators for upper extremity peripheral nerve block? And another question that asks, do you have experience with rebound phenomena of pain suddenly appearing when the block wears off? So concurrently, I suppose there will be analgesia administered. Thank you, Khan.
Thank you. For the first question, I think this is a good question. Both of the questions are good questions. Starting with the first one, and it's important for the safe application of regional anesthesia in children. I think I'll give a short answer for this one.
In my current practice, I'm not routinely using nerve stimulators for both upper and lower extremity blocks, but I believe that the nerve stimulator still has its own role for lower extremity blocks. And I think doing a dual control by using a nerve stimulator along with ultrasound is important for the security for the beginners, I mean. And so I recommend using it when needed. And this is up to the clinical conditions, experience of the practitioner, and also the patient itself. And for the second question, for the rebound pain when the peripheral nerve block wears off, I think that when we use the regional techniques as the part of multimodal analgesia regimens, the rebound pain is not a problem for ourselves. But if you use the regional techniques alone, then when it wears off, then the rebound pain is very awful for both the patient and also for us. So I recommend using it as a part of multimodal analgesia regimen. Even if we use regional text for surgical anesthesia, we should keep in mind that we should add some medicines as non-steroid anti-inflammatories, opioids maybe, according to the surgery itself. Thank you.
Thank you, Jan. I suppose as soon as the child is able to take orally, we should start oral analgesics as well, isn't it? And that would help to cover the period when the peripheral nerve block actually wears off. So thank you, Jan. The other question I have is to Dr. Brushali, and it's about the possibility of doing bilateral infraclavicular blocks for surgery. Is that possible, Dr. Roshali? Thank you.
That's possible with such enthusiasm. Yes, it is very much possible. Before I am so much tempted to put just one comment on the PNS. We need not have ultrasound all the time for blocks, and I totally accept that, and I agree. A PNS in children is very unique in the sense we really don't have to chase the number that we chase in an adult. Even if we get good stimulation at say 1 or even a bit lesser than 1, we really don't fine-tune it to 0.5 because the tissues are supple. So even if you get your responses at a higher current, go ahead, don't nudge much around an intraclavicular or a subclavian perivascular, because you might just damage a structure which is there. The pleura may be in the neck, or the pleura may be just underneath the posterior cord stimulation that you're going to look for. So this was one thought I wanted to share. Bilateral, I'm sure the bilateral intraclavicular block, we can do it. However, we can do it one after another. So let the surgical team work on one. Suppose if we have fractures of both. Cold orthopedics bilateral, they will never take up. But if we have both forearm fractures, then yes, we can, one after another, calculating the dose, halving them to begin with. Because they're going to easily take 1.5 hours on each hand.
Okay, that's good. So I suppose it's very important to calculate the dose as well, and we must know exactly how much we're infiltrating so that we don't run into trouble. Linda, is there anything else you would like to ask our speakers?
Yes, there is something else for Serpil. I think somebody would like to know when you should start lipid therapy. What symptoms do you expect when to start lipid therapy? I think they would like you to re-emphasize that.
You're
muted.
Sorry. Thank you for the question. It's very important to start the lipid emulsion as soon as you see the symptoms, like under anesthesia, the cardiovascular symptoms, since at the case reports, the success rate has increased whenever the lipid emulsion has started in 10 minutes. So please start as soon as you see the symptoms of cardiovascular arrhythmia or other symptoms of arrhythmia or cardiac depression, or seizures as well, if the child is awake. I don't think anybody does any blocks in awake children.
Okay, thank you for that. Thank you.
Oh, thank you for the question. It was very...
Okay, yeah. Oh, Cheryl, I wanted to ask you, although you had typed in your answer, but I think a lot of people would like to know about it. Maybe you can elaborate again on dexamethasone as well on the dose of dexmedetomidine.
Yeah, sure. So the dose of dexmedetomidine is 0.5 microgram per kilo to 1 microgram per kilo, up to a maximum of 50 mics per kilo in children. Dexmedetomidine is my additive of choice when I'm performing peripheral nerve blocks on children.
Oh, yeah.
And I tend to just give 1 microgram per kilo, unless for some reason I need to give it via another route. So if I've given it as a pre-medication or I'm running an infusion or something, I will reduce my dose perineurally. I've forgotten the other question, sorry.
It was dexamethasone, I think.
Oh, yes, that's right. Oh, that's right. There is quite good evidence in the adult population, which I think is reasonably applicable to children, that demonstrates that intravenous dexamethasone is as effective as perineural dexamethasone in improving the quality of the block and prolonging the duration of the block. So my practice is to give dexamethasone intravenously because you get the benefits of prolonging the block, while also getting the post-op nausea and vomiting benefits. Whereas if you administer it perineurally, you don't get those antiemetic benefits. I also would give intravenous dexamethasone to most of my children for that reason.
Yeah, it's such a magic drug, right?
Yeah, it is a magic drug.
Okay. Usha, do you have any more questions for our panelists?
Yes, I think one more for Jan. There is a question on blocks being given in sick kids, I think with coagulation profiles done. But I think even for adults, it depends on how sick the person is, the patient is, before we do a coagulation profile. And if we feel that's the best way to go, we would still go by the coagulation profile results. So what would your cutoff be in a child? Especially it's mentioned, in post-COVID infections and if children require a block. So do you have a cutoff, Jan? Thank you.
That's a question which I cannot easily answer because COVID is a very new problem for all of us, and we don't know even if the coagulation cutoff points are exactly the cutoff points are safer for us, and if it shows the exact coagulation parameters when we have only the points or some scores to show. I can say that I just do the block if I'm really sure and I can really identify the structures, and if I can use my needle safely to spread my local anesthetic without touching anything. I'm not trusting the coagulation parameters in these cases. Okay, I can say that I checked for the coagulation parameters. Yes, of course, but not just trust the parameters. So I perform when I'm really sure about doing it safely.
Thank you, Jan. Very good answer for them who are worried. So I think as we're running short of time, it looks like I have to end this Q&A session. And I hope the speakers and the participants enjoyed this session. It was really interesting, and thank you, everyone. I will now pass back the session to Joe, Singapore. Thank you.
Hello, everybody. Thank you everybody for the audience, the speakers, and our wonderful IT support, without which this webinar will not be possible. So before we close the meeting, just a few announcements. Thank you for your patience. All ASPA members are invited to attend our annual general meeting that will follow immediately after this webinar. For those who have not registered yet, kindly check your email for the ASPA invitation or email the ASPA Secretariat, Jessie Tan. Her email address is in the Q&A section. And save the dates. The World Federation of Societies of Anesthesiologists will be hosting the 17th World Congress of Anesthesiologists this coming September 1st to the 5th. Please visit their website to register. Singapore will also be hosting our own ASPA first virtual conference this coming November on the 13th and 14th with the theme of navigating new frontiers to improve pediatric outcomes in Asia. Please go to the website and register and submit your abstracts. I'm also inviting everybody to register for the half-day ASPA pre-conference virtual airway workshop this coming November, just one day before the actual conference. So the airway meeting or the virtual airway workshop will be on the 12th of November. Registration is free, however, slots are limited and priority will be given to ASPA members. And certificate of attendance for this webinar will be automatically generated and forwarded to those who submitted the post-webinar survey. The post-webinar survey will be emailed to you tomorrow on the 19th of July at 5 p.m. Singapore time. Please ensure that you have correctly keyed in your full name and email address. And finally, for those who wish to watch this webinar recording at a later time and date, kindly follow us on YouTube, like us on Facebook, or visit our ASPA website. Thank you for your patience and staying to the end. Goodbye and have a good evening. Bye.